We know many people end up with a risky pileup of prescribed medications. Many efforts have been made with varied success to correct this problem. Yet we've usually focused on physician behavior when there's another effective lever: pharmacists. That's the topic of this week's Healthcare Triage. About 30% of older adults in the United States and Canada filled a prescription in the last few years for one of many medications that the American Geriatric Society recommends they avoid. Such drugs can lead to more harm, like cognitive impairment or falls, than good, and often safer options are available. Dr. Kara Tannenbaum, a professor of medicine and pharmacy at the University of Montreal and director of the Canadian Deprescribing Network, told me that older adults take a lot of pills. 66% take 5 or more per day, and 27% take 10 or more per day. It's not easy to get patients off such drugs, though. Physicians often don't have enough information about what patients are taking or may lack the time to talk to them about these medications. They fear that stopping the drugs might cause harm or make patients upset. To explore the possible role of pharmacists, Dr. Tannenbaum conducted a large randomized controlled trial over 4 years in community pharmacies in Quebec. The results of the study were recently published in JAMA. Patients 65 years or older were randomly assigned to one of two groups. In the intervention group, pharmacists gave both patients and their physicians educational materials on the specific drug that might have been inappropriately prescribed. Such brochures could be delivered by mail or in person. The control group got the usual care with no educational materials. Drugs that were targets for deprescribing included sedatives, first-generation antihistamines, glyburide, used to treat diabetes, and certain non-steroidal anti-inflammatory drugs like ibuprofen or naproxen. The main outcome of interest was the ending of a prescription for one of the 4 medication classes 6 months later. About 500 patients, average age 75, participated in the trial, and about 90% of them completed it. The intervention made a difference. Within 6 months, 43% of the patients in the intervention group had stopped taking one of the selected medicines. The corresponding figure was 12% in the control group. In medicine, we often focus on the traditional doctor-patient interaction. We tend to ignore practitioners who come into contact with patients more than physicians, who in this case could hand over brochures personally. In this study, pharmacists were also paid to send information to the patient's doctors. Similar studies trying to enlist pharmacists are rare, but not unknown. In a 1996 study in the American Journal of Medicine that randomly assigned 208 patients, half of them had a pharmacist in a Veterans Affairs medical center review their medications and make recommendations to their physician. This resulted in improvements in prescriptions in 24% of patients versus 6% in usual care. A 1998 study published in JAMA encouraged pharmacists to contact physicians by alerts when they were employing drugs that were not ideal in the care of older people. They were able to reach physicians just over half the time and saw changes in prescriptions about a quarter of the time. This was not a controlled trial, however. A 2014 study in JAMA Internal Medicine focused on direct-to-consumer educational materials from pharmacists to reduce inappropriate benzodiazepine prescriptions for older people. It worked 27% of the time compared with 5% in usual care. And a 2001 study in the Canadian Medical Association Journal focused on messages sent to physicians only and found no significant changes. Dr. Tannenbaum, who was an author of the recent JAMA study, thought the communication was essential to her project's results. First, they asked primary care providers what information they needed to safely deprescribe patients' medications. Then, they provided pharmacists with a template on how best to communicate the evidence about deprescribing to physicians. When pharmacists gave patients the same information, targeted to medications the patients had been taking for a while, everyone was on board and eager to talk. Of course, this study took place in Canada, and pharmacists' scope of practice may differ in parts of the United States and elsewhere. The pharmacists were also reimbursed for physician contact, which might not occur in the United States and elsewhere. Pharmacists have seen increases in their scope, especially with respect to contraception in Oregon and California in the United States, which tends to be supported by patients as well. Much like another recent study we covered here at Healthcare Triage involving barbershops and pharmacists, this study provides evidence that seemingly intractable problems can be overcome by expanding the focus of our interventions. There are many more professionals involved in healthcare besides physicians. They can help make healthcare better. Hey, do you like the show? It really helps if you subscribe or like it wherever it is on the screen right now. And another good way to support the show is at patreon.com. Go to patreon.com/healthcaretriage. We'd especially like to thank our research associate Joe Sevitz and our Surgeon Admiral Sam. And if you want more content, go to our podcast. It's great. the Healthcare Triage podcast, wherever you download podcasts or wherever they're available. And of course, my book, The Bad Food Bible, still on sale in stores. Appreciate it if you pick up a copy.